All right. Today, North Carolina Community College Oncology webinars. Oncology Career Pathways is the name of today's presentation. This is a new presentation. We've never done this before. We're very excited about it. We have Patty Morfeld, we have Shanabel Santer Torres, we have Jessica Church and Isaiah Zipple, and we'll get to meet each of them in just a moment and then hear from each of them. So I did mention poll everywhere. This is what our first question will look like. There are many paths for someone in an associate degree, with an associate degree. So we're going to say true or false. You let us know what you think in just a minute. But before we do that, we want to meet each of our presenters. So first off, Patty Morfeld, RN, BSN, OCN. She's a native Texan and now a North Carolinian for 10 years. She has two fabulous sons, ages 20 and 22, a less gracefully aging dog named Stella, and two turtles named Sam and Frodo. I think we had a typo, Patty, because we had Sam and we said, no, that's got to be Sam and Frodo. Or did we get it right? Okay, good.
In comments.
And she's pursuing an MSN with a focus on patient outcomes and special interest in improving patient and staff safety. And Patty, what's one other thing we should know about you? Welcome.
I make really good salsa.
All right. Any favorite kind?
Just, the standards with the serranos and some jalapenos. And when we first relocated from Texas, my youngest son at the time was very distressed about not having access to Tex-Mex food. And so anytime we tried a restaurant, there was a poll involved, and he had a sheet where he wrote down the chips and the salsa and the tortillas and graded things to see if it was worth, taking his grandmother to when she came to visit. So,
that's great. Well, thank you and welcome. And Shanabel Santer Torres, CPHT, has been a CPHT for 15 years and has worked in different pharmacy settings, including retail, hospital, and now more clinical. She's currently working for UNC Healthcare in their specialty pharmacy. Her pharmacy focus is oncology, but she still helps patients in other specialties. Her current role involves collaborations with pharmacists and doctors and monthly check-ins with patients. Shanabel, welcome. And what's one other thing we should know about you?
I am originally from New Hampshire.
Oh, wow.
And I travel very frequently up there and to many different places.
Great. Well, welcome. We're really glad to have you. And Jessica Church, MPH, RT, CMD, is the manager of the Radiation Therapy and Medical Dosimetry Education programs at UNC Medical Center. She is a graduate from UNC Chapel Hill with a bachelor's degree in radiologic science and certificates in radiation therapy and medical dosimetry. She has experience in teaching and academic advising and has mentored radiologic science professionals in various stages of their careers. Jessica enjoys working with students and is excited to be presenting on career pathways in radiology today. Jessica, welcome. And what's one other thing we should know about you?
A fun fact, I lived in Australia for almost 3 years.
Wow, that's great. Well, thank you. Welcome for being here. And finally, Isaiah Zipple, who's coming back to us for the second time in about a month, CTR, and he has a BS in biology and health sciences from Duquesne University. He has worked as a certified tumor registrar since September of 2015 and in a team lead role since August of 2020. He is also the chair of the nominating committee for the Association of NC Central Cancer Registries. Isaiah, welcome.
Thank you.
And how about you? Something we should know outside of your professional information there.
I was born and raised in North Carolina and a pretty avid kayaker.
Great. Well, glad to have you here. And let's see, we'll see how we're doing. Looks like people are coming in favor of true on that many career paths for someone with an associate degree. For our panel, does that seem about right? All right, we're getting lots of nods. So we're going to go with well done from our guests here today. And nursing career pathways, Patty, we'll let you take it away from here. And Patty, if you hover a little bit over the left portion of your screen, you'll see you've got arrows, so you can just go ahead and you don't have to say next slide. You can just go right on through your presentation.
Great, thank you. If I can get a handle on the mute button, I'll be in good shape. Thank you all so much for taking the time to visit with us today and give a listen to some of the fabulous things you can do working in oncology and healthcare. Our first question for Poll Everywhere is, do you know anyone who's been impacted by cancer? And I'm going to take a random guess and imagine that I would say we're probably at close to 100% on that, possibly maybe 97, 98. But I think at this point, if you're in one of our community colleges, you have probably experienced a cancer diagnosis with a family, friend, someone you work with. So being a nurse is very challenging. And obviously in this last several years, we've had more conversations about healthcare and the challenges for everyone working in healthcare, no matter what their role. And so I will tell you though, that before the pandemic, and when people would say, oh, you're a nurse, what kind of nurse? And I'd say, oh, oncology. And then I'd either get the look of, oh, or the look of, oh, you must be an angel. Anyone who's familiar with me can absolutely reinforce that I am in fact not, that I do not have a halo. And that, but the sad part and the part of the, oh, sympathy thing is that being a nurse is a challenge no matter what field you choose to pursue in it. One of the great things about being a nurse in oncology, for me personally, and for most of my colleagues, would tell you that we hear frequently when we're interviewing people or when people have been in oncology and are thinking about trying something else, it's working with the patients and the caregivers and realizing that as you're going through nursing school or some of those things, that being part of that journey for a patient and caregiver, their family, is it's an incredible privilege to be with people at some of the hardest, most intimate moments of their lives when they're having to really make some very hard decisions sometimes. Sometimes it's just the stresses of getting through the actual treatment itself, but it's very special to be able to build those relationships with people. And if you enjoy getting to balance both your heart and your head, it's a great professional journey. There's also lots of happy endings. Unfortunately, lots of people still have ideas about cancer and oncology medicine that it's always bad news. The reality is that we take care of lots of patients that either have a chronic type of cancer where we're going to see them every 3 weeks for the remainder of their life, but the remainder of their life may be another 10 or 20 years because their disease is under good control and the medications that we're able to use are really managing it well. And that's amazing because, 25, 30, 45 years ago, we never would have been able to say that. So for a lot of patients, you get to really develop long-term relationships with them and their families. And it's incredible to get to see people go from having their initial diagnosis and then getting through treatment and surgery maybe and radiation and other things, and then go on to recover and go back to work or get back to retirement in some cases. We had a patient who was with us for literally almost 23 years, and she started off with one diagnosis and was on a clinical trial and did very well for many years. And then when she started, her daughter was in high school. It was her only child, her and her husband. And over many years, she got to be with us. Her daughter went on to graduate from high school and then graduate from college and then get married and then eventually become a parent herself. And so through all of that, that patient went on to become a grandmother. And when she announced that, we were all so excited. We even had a little grandma shower for her because we were just delighted. And she did pass, but she passed after 23 incredible full years. And during all along the way, different people, we made that possible. And that's an incredible gift to be able to be part of that. I'm sorry, I lost my train of thought there. So where can you start with an associate's degree? In nursing, the move is really towards trying to get most staff nurses to eventually have a bachelor's degree. But initially, nurses are absolutely can arrive and be well prepared to start from a community college setting. And lots of nurses seek that option, especially people going back to school maybe after other work or after being at home and being a parent or who knows what. And the great thing about nursing is that depending on what part of your life you're in, whether it's having small children or trying something new or moving or just any number of things. There are different ways to kind of tailor what you want to do professionally. As a staff nurse with an associate, you'd be able to work in an oncology setting, in an inpatient or an outpatient role. Inpatient oncology nursing can mean sometimes that you're giving people chemotherapy or medications to help treat their cancer. It can also mean sometimes you're doing lots of supportive care like transfusions and electrolytes and IV fluids, medicines to help with nausea or any other side effects. Bone marrow transplant is also part of the oncology family, and that's another thing that inpatient bone marrow transplant nursing can give chemotherapy right before a transplant because that helps clear out a patient's bone marrow in preparation for the new cells they're getting. And then you may actually help with infusing those brand new cells, which is pretty neat, being there for a patient's brand new birthday, which is how we typically celebrate that. Outpatient oncology and BMT nursing or bone marrow transplant nursing can include everything from lab work to transfusions to helping teach people about the medication they're getting, helping teach people ways to keep themselves healthy during chemotherapy, helping people manage their medications and learn about how to do that, helping make sure that if patients need help accessing resources like the social work or nutrition, things like that, that we get them connected to the right people. In a big piece of what we do here, especially in my department, is infusions. And so our nurses become very capable with putting IVs in people's arms, but then we also have all kinds of amazing devices like central lines and ports and Hickman catheters that are placed inside a person in their chest or in an arm, hip lines, things like that. And so that can be a huge piece in oncology, is helping make sure that people have good access in their veins so that they can tolerate their treatment. And some of the medications we give require specialized equipment. Taking part in research is another piece, especially here at UNC. Having been here for a long enough time now, we've been able to see myself, I've been in my department now for 12 years, and I've actually taken care of people who were in the first beginning phase of a clinical trial for the FDA, where a very small group of humans were getting the drugs for the first time. And being able to see that medication be initially started there and then go through the next couple rounds of trials for people and the next couple stages for the FDA, and then suddenly watching something on TV and suddenly seeing a commercial for a medicine, because now everybody can get it and it's a standard of care kind of medication. And so it's pretty exciting to be able to be part of caring for people and seeing that this medicine that until 10 years ago nobody had even thought of is now something that people can benefit all over the country and in fact all over the world. I have a brother-in-law who had lung cancer a few years ago, and one of the medications he ended up being treated with was a medication that I was a nurse for one of the clinical trials here. And so knowing that that medicine was available for him and wouldn't have been if he'd been diagnosed earlier was really, really exciting for me as a nurse. And as a sister, of course. Why start with your associate's degree? So I became a nurse myself. I did not finish my degree until I was 35. I went back to college after the death of my husband. And I had gone to college right out of high school, and I was a terrible student. I really did want to be a nurse, but I did not have the attention span or the organizational skills to actually land the plane and get a degree. And so I kind of wandered major to major and tried lots of things and collected lots of hours and spent a lot of money. Don't regret it, but I would certainly advise a different path if possible to save yourself some grief, especially because it is even more expensive right now, of course, to get a degree. One of the great things about an associate's degree in nursing, especially, or any part of healthcare right now, is that, frankly, we'll pay for you to get your bachelor's degree, and you should absolutely take us up on it. Hospitals and healthcare organizations now and going forward into the next many years are going to need people who are ready and eager and want to join the professions that we're talking about today. And so here at UNC, for example, we hire in staff who may have their associate's degree in nursing, and then we set up, that's part of their employment. You have 7 years to complete your degree. And so it'll tell them, you know, by the 5-year mark, you should have started. But it gives people an opportunity to get settled, to learn their new role, and then apply for tuition reimbursement or waivers to find the right program for them and for their life, or to go at a snail's pace if that's what works for them too. I started working on my graduate degree 2.5 years ago. My program would really like me to be done, and I am not, because I am going one class at a time. And that's because I know myself, and I'm working in a very demanding job, and I know that I would not be a good student going full-time right now. And so I go very part-time. But that's one of the benefits of me being here at UNC for all these many years, is that when I finish, UNC will have paid for everything except maybe a couple books. And that's awesome. That's fabulous. And I think I deserve it. And I'm glad they've made that investment in me as an employer. And I'm paying it back to them in the care I give to both the patients and caregivers I come into contact with, but also to my colleagues in my department in the way that I help support our new staff and all of those kind of things. I am happy to answer questions at the very end. I'm going to hand off to our next presenter, but no matter whether you choose oncology or you don't even choose, you just get started, I hope you will pursue your professional life in healthcare. There are lots and lots of many different ways to help. There's plenty of places for you. If you're not a people person and you'd rather never see a human again, there's ways for you to do that. And if you are a people person, or you change and halfway through your professional life you decide you're not anymore, there's going to be plenty of room for you. So thank you so much for your time, and thank you for your interest in our programs.
Patty, thank you so much. And, you know, I'm always amazed at what a small world it is. And Patty was just incredible. Two of my closest family members are cancer survivors, and she played a really significant role in the care of both of them. And one of them is now getting an advanced nursing degree, and the other is in community college. So, you know, just a very small world, and very privileged for the care that she provided for our family. All right, we'll go ahead and turn it over to you, Shanabelle. And if you want to go ahead and unmute, or you can go ahead and move the slides and take it away.
All right, thank you. Hi, everyone. My name is Shanabelle Torres. I'm a certified pharmacy technician for the past 15 years. I started off at 18 years old, right when I moved here from New Hampshire, at Walmart as a cashier. and one of the pharmacists had been coming through my line and checking out, and we just started conversing, and he had offered me a job in the pharmacy. They had an opening, and she saw something in me that I didn't see myself, and she asked me if I was interested and that she would give me all the on-the-job training I needed. And I took a leap of faith and I went to the pharmacy, and it was the best decision I ever made for myself and my family. I worked at Walmart for several years, and then I transferred to the hospital setting, and there I was more interacted with the patients, and I delivered prescriptions to their bedside and did inpatient, outpatient, and also the employee pharmacy there. And then COVID happened, and while delivering prescriptions to patients' bedsides, I had gotten pregnant. So it wasn't a good idea with the start of COVID, not knowing exactly what it was and so forth. And then I got the opportunity at UNC to work in the specialty pharmacy. And it was a work from home job, and that's not very common. I had never heard of being able to work from home as a pharmacy technician. I always thought, like you had to be somewhere counting pills, and I had this great opportunity. So now I work for UNC Healthcare in the specialty pharmacy, and I help various disease states, but focus on clinical care and hematology and oncology. So the patients that I help are benign hematology, neuro-oncology, GI, GU, leukemia, lung cancer, lymphoma, and melanoma. So I work with all types of patients, and from severely ill to patients that have been taking these medications for over 20 years. And when I call them, they just say, oh, everything's fine, to send me my medication, because they've been just doing so well on the prescriptions, like the medications that have been prescribed to them that we fill for them at our pharmacy, which is amazing to me, because before this, I never knew that people could have cancer for so many years and just take one pill and be okay. So with the specialty pharmacy, I collaborate with not only our production team, but also other health professionals, such as the pharmacists, nurses, and physicians, to ensure continuity of care by completing monthly check-ins with patients. I identify potential adherence concerns, update their medication list to avoid drug interactions, and identify possible effects and other factors such as cost or social determinants of health, which may impact the patient's ability to start and maintain treatment. In order to become a pharmacy technician with the North Carolina Board of Pharmacy, they require you to hold a high school diploma or equivalent, or are currently enrolled in a program that awards a high school diploma, be employed by a pharmacy holding a valid in-state pharmacy permit, or complete a training program approved by their supervising pharmacy manager. Or you could also get your certification issued by either the Pharmacy Technician Certification Board or the National Health Career Association. And in order to keep those licenses or certifications valid, you need to complete a minimum of 20 hours of continuing education every 2 years, which includes 1 hour of pharmacy law, 1 hour of patient safety, and 18 hours of pharmacy technician subject matters. The typical career paths for a pharmacy technician are usually community pharmacies such as Walgreens, CVS, Walmart. You have the nuclear pharmacy, independent pharmacy, pharmaceutical sales, pharmacy buyer, radiology, compounding pharmacy, and you have the regulatory and compliance supply chains as well. And then for the hospital settings, you have inpatient, outpatient, specialty pharmacy, medication assistance, and I know a lot of people have heard of the traveling nurses, but you actually have traveling pharmacy technicians. So you could travel all over the United States with your certification and go help out other hospitals or anywhere that needs assistance. So if blood's not your thing, like me, I could never do it. You could also travel the world and be a pharmacy technician as well. You have the academic, which would be teaching or training future pharmacy technicians, and supervisory or management level positions. And with all these opportunities in each of the settings that allow for personal growth and development, there's opportunity and doors that can open for you for supervisory or management roles. I have a supervisor now, and she's a pharmacy technician, but she supervises all the pharmacy technicians below her. So there's so much different room for growth as a pharmacy technician that a lot of people are not aware of. And they also have advanced certifications, which just started not too long ago, which helps us even become more advanced in our job field. So you have their certified compounding sterile preparation technician, billing and reimbursement, controlled substances diversion prevention, hazardous drug management, immunization administration, the medication history, medication therapy management, point of care testing, and regulatory compliance, supply chain and inventory management, technician production as well. And with many organizations, like Hattie had said, there is a tuition reimbursement for higher education, and advanced certifications and further education typically results in higher pay in your field. And my question for you with the poll was, what is the minimum number of continuing education CEs that a pharmacy technician needs to complete every 2 years? And the answer is correct, be 20 hours.
Great. And thanks so much to everyone for jumping on those poll questions. We really appreciate it.
Awesome. And so a lot of people are not aware of what happens once your doctor actually sends a prescription to the pharmacy. They think that it's sent and then you just get the bottle sent to you. But once a doctor sends a prescription, the triage technician will enter the prescription in and then identify the needs, or if it needs a prior authorization or copay assistance. If it needs assistance, they'll send a referral to the medication assistance team, and the medication assistance team will then do the prior authorization, or they'll try to find assistance for the copay. So we have manufacturer assistance, and then there's also grants that are given to UNC to help and make medications more affordable. As you all are probably aware, oncology medications are extremely expensive, and it's life or death for our patients. And so we try our best to get the prescriptions at least less than $25 for our patients, which is amazing when some prescriptions are over $20,000 per month. So there are grants out there, and we do get medication assistance from the manufacturer itself. And then once that's done, it will be sent to the pharmacist, and then the pharmacist will check the patient's profile, make sure there's no drug interactions, and then they'll call the patient and educate them on the proper administration of it and the management of their medication itself. After the following month, that's where I would call the patient and schedule their next refill. We like to call them at least a week before their medication runs out, and then the medication is delivered to their doorstep, so they don't have to go anywhere or stress about the medication being missed doses. And then depending on the type of medication it is, the pharmacist will give them a call back, usually every 6 months or every year. But other than that, myself, I'm the one that solely speaks to the technician, to the patient, unless there's an issue with their medication. And my final thoughts are that I chose to become a pharmacy technician and remain doing so for the past 15 years because I absolutely love what I do. I wake up every morning and love my job. I couldn't picture myself doing anything else. And some days are very difficult, especially when I'm told that one of my patients has passed, because I speak to them sometimes several times a month, and you build a relationship with them. They tell you about when their grandkids, had their first birthday, or they ask me about my son. I have a 1-year-old, and they're, like, what's he doing this week? Like, has he learned anything new? How's swimming class going? Like, we build a relationship with each other. So it becomes very hard when I find out that one of them has lost their battle. But on the bright side, there's so many people that I speak to every day that are just telling me how thankful they are for, like, UNC as a whole, because of all that we do for them, and how, like, these medications are letting them enjoy another baseball game with their grandchildren, or being there for a graduation, or being able to dance with their, like, daughters or their sons at their weddings, because we were able to, like, make a big difference for them. The pharmacy does get unnoticed a lot, but we do make a difference, and I'm proud to be a part of it, whether it's delivering the medications to someone's bedside before being discharged, so their family or themselves, they don't have to go to a retail pharmacy for it, or doing the legwork of getting the manufacturer assistance for someone so they can afford their medication, or calling a patient to schedule their medications for them so they have one less thing to worry about, because they have enough on their mind and on their plate that we just want to help them out just a little bit more. Thank you guys so much for your time. Appreciate it.
Annabelle, thank you so much. That was really informative. All right, and we'll move forward. And Jessica, we'll let you take it from here.
Awesome, thank you. So my poll everywhere question was, have you ever had an X-ray? And it looks like that many of you have. And I imagine when you hear the term radiology, or you're in a hospital or clinic setting and you pass the radiology department, you're thinking about X-rays. But radiology is really an umbrella term that covers a lot of different specialties or modalities. I've chosen 8 examples here, including cardiac or vascular interventional radiology. This is a section of radiology that for oncology patients might include inserting stents or catheters, tubes, and lines into vessels, maybe to open them up because the tumor has closed them. Computed tomography, magnetic resonance imaging, mammography. Those are starred or have the asterisks beside them, so I'll talk about them in the following slides. Nuclear medicine technology. Someone mentioned the use of medications in terms of radiology as well. So nuclear medicine technologists use radiopharmaceuticals or radioactive drugs as part of the imaging process, most likely in the positron emission tomography or PET scanning area. Those types of images are particularly helpful for oncology patients in looking at areas of cancer spread, metastases throughout the body. Essentially the radiopharmaceuticals in areas of high metabolic rate or tumor activity light up. And so the physician can identify areas that maybe need additional treatment or treatment in general. I'll talk more about radiation therapy and radiography, and then lastly, sonography. So most people think about images of babies when they think about sonography, but sonography can also be helpful in visualizing organs and vessels as well for oncology patients. It's also helpful in imaging of the breast for breast cancer. So lots of different areas to investigate within radiology. So those who practice in the field of radiology are called radiologic technologists. You may also hear them referred to as X-ray technicians. We like to avoid that because we're not just button pushers. We like to say that radiology is a blend of art and science. So the art aspect in terms of taking and analyzing images, and then the science portion in terms of using the latest and greatest technology. The primary responsibilities of radiologic technologists are patient care and radiation safety. So specifically the patient care aspect led me to become a radiologic technologist. I liked interacting with patients, and in the typical X-ray setting, you at least get 15 to 20 minutes with a patient where you're positioning them for the procedure and you're taking and analyzing those images. And then I furthered my career into radiation therapy. And a nice aspect there is that our patients visit us every day, Monday through Friday, between 5 and 8 weeks. So we get around 30 minutes there every day with our patients. And like others have said, you build relationships with your patients where you find out what they like, what they don't like, how their family is doing, what they are doing during treatment, or what they'd like to do after treatment. So it's nice to build those relationships. It's also nice for maybe those who enjoy aspects of nursing, but don't really want to draw blood or maybe do some of those other activities. And so you get that patient care relationship, and then more kind of in the outpatient setting. And then related to radiation safety, there are physics prerequisites involved. So I know some students sort of shy away from some of the science courses, but overall you have a large responsibility. You're delivering radiation to patients, which we know carries some degree of harm. And so it's really important that you understand those physics principles and that you're able to apply the radiation safely, whether it's in the diagnostic setting, taking those x-rays, or maybe in the therapeutic setting where you're delivering a patient's treatment. So under those responsibilities, primarily you're creating images of patients' bodies using specialized equipment. And based on the specialty or modality that you're involved in, that equipment will vary. I'll talk about some of the examples in the following slides. If you're practicing in nuclear medicine, you may be responsible for both preparing and injecting those radioactive agents, radiopharmaceuticals. In various settings, you could also help physicians perform procedures. So there's a particular technique in X-ray called fluoroscopy, where you're using kind of dynamic X-rays, looking at X-ray images in real time, sort of taking video of the patient's insides. And you're working very closely with the physician to position the patient properly and to get the images that are needed for diagnosis or treatment. There's also an option to become a radiologic assistant, where you're assisting procedures much like a PA would do with a physician. So lots of opportunities to work with physicians there. And lastly, if you choose radiation therapy, you're responsible for delivering therapeutic doses of radiation. So here you're delivering very high doses with the goal of either curing a patient's malignancy or palliating or providing pain control for a patient with cancer. We also treat patients with benign diseases, those that benefit from radiation. So I believe, like Patty said, it's not all doom and gloom in terms of radiation therapy practice. There are lots of success stories and lots of pride associated with the job when your patient has a good outcome or they're able to reach some of their goals even at the end of their life. So in general, radiologic technologists work in a variety of different work environments. You'll find them in various areas of hospitals. You can also work in physicians' offices. That might include outside of the oncology realm, just guess, routine practitioners or maybe chiropractors, various outpatient centers in the oncology world that might be for follow-up after treatment or during treatment where we're monitoring progress, and then in various laboratories in terms of those radiopharmaceuticals. So lots of areas there. If you're not particularly interested in working in a hospital setting, you can work in some of the smaller facilities helping out as well. So focusing on a few of the modalities that are common to oncology, the first is radiography. So this is typically what you think of in terms of radiology or X-ray. Those who practice radiography are called radiologic technologists, and they're certified by the American Registry of Radiologic Technologists. They get to add a few initials behind their name. So if you happen to see a name tag with RTR, that means that the person is certified in radiography. Their job is to create images of patients' bodies using X-ray equipment. So you can see in the image there, the radiologic technologist is taking an image perhaps of this patient's body. There are lots of different settings here. So routine X-rays, emergency facilities, or specialty clinics like oncology, and you can work with adults or pediatric patients. In oncology, a very important modality is mammography. Those who practice mammography are mammographers, signified by the letter M there, and they're primarily imaging patients' breasts. So we know that breast cancer is very common in the US, and so we can help with routine screening as patients come to the hospital, maybe to see if they have a malignancy, and then also with follow-up as they're coming back after their treatments. If you've had an X-ray, it's likely that you've also heard of computed tomography, sometimes called CAT scanning. In this case, we're creating 3D images. So as opposed to the regular X-rays you're used to seeing, it's kind of like we're taking images of a patient as slices of bread. So you're looking at the patient from the feet to the head and in sort of all different directions. You're able to see what's going on inside the body to help with diagnosis or for treatment. All of those modalities use X-ray equipment, so you're exposing the patient to X-rays, whereas magnetic resonance imaging, or MRI, involves the use of magnets. So there's no X-ray exposure here. The images look very similar to the CT images, but again, you're helping create those for both diagnosis and treatment. And then lastly, a little bit different modality, radiation therapy. As I mentioned, you're primarily working with oncology patients, but we do treat some benign diseases, and you're helping with their therapy. So there are different goals with treatment. We can try for cure, or we can try for pain control. And a lot of, I guess, concerns for students are X-ray exposure. I mentioned it does have some harmful properties. There's actually no radiation dose to the radiation therapists themselves. They're well protected behind a very thick concrete wall, so they can treat many, many patients every day and not receive any dose themselves. So there have been many studies for protection there. So that's primarily the area that I'm focused in, and then lots of specialty areas there. So if you'd like to learn more about radiology, you can visit one of these two sites. The ARRT is our certification board, so they'll provide you with more information about each of the modalities mentioned today. And then the ASRT is their professional society, so they have all of those activities there for you to look at. If you're particularly interested in a radiology career, you can find an associate degree program. If you visit jrcert.org, you can select students and find a program, and then filter for certificates or associate degrees. So I'm happy to answer any questions at the end. Thank you for your time.
Great. Jessica, thank you so much. And Isaiah, we'll go ahead and turn it over to you for cancer registry.
Great, thank you. I'm kind of glad that I got to go last. Tumor registries and what I do as a certified tumor registrar kind of combines lots of the things that we've talked about today. Kind of the 1,000-foot view of what a tumor registrar does is we collect a large body of data about a patient's diagnosis and their treatment, and then we could create abstracts on a patient level about their history of their cancer, how it was diagnosed, how it was treated, and then we do follow-up on every patient once a year for the life of the patient. So that's kind of the 1,000-foot view, but we'll go into some specifics. Kind of to start off the talk, I wanted to kind of pose the question of what is cancer? As tumor registrars, we're really interested in the type of cancer that a person has. So when we talk about cancers in general, we can break tumors into two groups. And a tumor is really just a cluster of cells that are experiencing uncontrolled cell growth. Normally, when there's a cell life cycle, there's kind of pre-programmed cell death, but in tumors that cell death does not occur. So you get overcreation of tissue, basically. We can differentiate tumors into two categories. They can either be blood-based or they can be solid tumors. And those solid tumors are specific to certain organs depending on where they arise. Cancer stage indicates how advanced the disease is, and certain tumors, depending on where they originate, certain tumors behave differently than others. So the question is, why do we collect cancer data? And this movie Moneyball is kind of my answer to that question. For anyone who hasn't seen the movie, Moneyball was a group of coaches in Major League where they figured out a way to recruit players differently based specifically on data rather than traditional coaches' instincts on players. And cancer registries really do the same thing. We collect data to better inform how we treat different cancers. So, what type of information do we collect? We collect information like demographics, and this will go into patient information, certain social factors like smoking, alcohol use, family history. What sort of job does the person have? Certain jobs have occupational hazards that one would not necessarily expect. We also collect diagnostic information. We collect information on how was this cancer diagnosed. We review imaging. We collect information pertaining to a patient's biopsy. We'll also, as of 2020 and 21, we've been collecting COVID-19 data to see how COVID has impacted or specifically delayed potentially their care. Staging, we stage every cancer. So we look at every type of cancer has a specific staging schema. And we'll use things like imaging and pathology reports to create a total, both a clinical stage and a pathologic stage if it has not been assigned by the physician. We then also collect information on treatment, and we kind of summarize all of the treatment modalities that were used. These can be surgery, radiation, chemotherapy, immunotherapies, hormones, We collect all these different types of treatment modalities and kind of compile them for every abstract. With follow-up, we also will do follow-up on every patient once a year for the life of the patient. This helps indicate, all of this information is being used for studies, and it really helps inform projected lifespans based on a tumor and what stage it is in presentation. First course treatment. We are primarily concerned with first course treatment. So first course treatment is kind of defined by the treatment that a patient receives before they have tumor progression, or if they are put on some sort of maintenance therapy. Maintenance therapy can be some sort of treatment that you'll be placed on for a long period of time. With thyroid cancer, for example, people will commonly be placed on Synthroid as a hormonal replacement if they've had thyroid surgery. And so this is kind of considered maintenance treatment. And so we record things like maintenance therapy. Another example would be tamoxifen if a patient has breast cancer. So these are, again, just the different treatment modalities that we collect. And all of these different surgeries, chemos, radiation, these all have a set of very complex codes that are assigned to every section. And they're very specific to the field of tumor registry work. It's a several 100-page manual. And if you were to become a tumor registrar, it's not so much of knowing everything that's in the manual, so much as learning as how to use the manual to look up the information that you need. Follow-up, we collect follow-up once every 15 months. We try to keep it to once every year for the life of the patient. This has to do with certain accreditation that is maintained by the hospital. This is a component of that accreditation. We have to maintain 80% of all of our cancer patients and 90% follow-up rates for anyone that was diagnosed in the last 5 years. And that's a huge volume of work. And we have 2 full-time staff dedicated to doing nothing but, doing this sort of follow-up data collection. To give you some idea about numbers, we currently do follow-up on almost 26,000 patients annually. So every year we are collecting new information on these patients every single year. I included some pathways to become a CTR. Most people have, when I started, I'd never heard of a CTR before. And I imagine that's the case for many on the call today. I kind of came across it completely by accident. I was in the same department that our tumor registry is in for the hospital. And I actually started doing follow-up, and I then decided to pursue my CTR credential. So my kind of guess is there's a third pathway on the next slide. Kind of the either path 1 or 2 are very achievable pathways. I achieved my CTR while working full time, and one can certainly get into it with some community college level coursework, and then you pursue a focus specifically in cancer registry management. And there's the third pathway. This one is less common. If anyone is interested, I have the link below takes you to these same pathways if you want to look into it further. I would also highly recommend the HEMA Cancer Registry Management Program. It is the pathway, or the program rather, that I used to get my associate's degree in cancer registry management. So if anyone is interested in those, they're definitely worth looking into further. And I'm happy to answer any questions. Oh, I think we have the poll everywhere question as well. So collecting patient level data allows researchers to monitor cancer trends and evaluate the best practice of treatment modalities. And y'all right, that is true.
Right. Isaiah, thank you so much. This is terrific. And we do have time for questions now. So bear with me for just one moment. I need to bring up my screen so I can make those pop up as we get those. So I'll do that. And then while I'm doing that, I have a question for all of you. You know, it seems like there's a really a broad variety of different and very fulfilling opportunities here. I'd be interested in hearing thoughts from any of you on what's helpful in terms of determining what kind of career might be right for you. You know, if somebody's listening and saying, gosh, I really would be interested in doing something working with cancer and with cancer patients, what would steer somebody to one of these versus another? And anyone at all, or I can pick on somebody too.
I would say that for the most part in the profession of nursing, you have to at least be able to tolerate human beings. So if tolerating human beings in their very hardest times is not something you want to do, then nursing is probably not the right place in healthcare. That said, there are lots of other places though where you don't have to provide hands-on kind of care. I think one thing I found for myself over the years is that things that I didn't think I was good at earlier in my professional life, or even earlier before I became a nurse, skills that I didn't think I had, I did have. I just maybe needed to learn them differently, or as I got older and more mature, kind of that part of my brain opened up. And so I wouldn't necessarily limit yourself at the very beginning. I'd kind of see what you're really interested in, and you know, if you have a great attention to detail and you really like all those kind of, you know, statistics and all of that kind of stuff, then there's pathways for you there with some of the things Isaiah was talking about. And you know, if you really like the medication piece of it, there's pharmacy, there's lots of different options. So I would encourage you to try and kind of put your feet in the water and see what interests you.
Great. And community college is, of course, a great place for that. Jessica, Shanabelle, Isaiah, anything you'd like to add to that?
A little bit less sorry.
You can go ahead.
In COVID world, it's a little more difficult, but there are opportunities to shadow different careers. So you can contact local facilities or even the hospital and see what opportunities there are. If you're interested in one particular area, you can kind of bounce around to other areas even in one day.
Jessica, that's a great idea. And I'm always saying to students and to my own kids who are students, it's amazing. People love to talk about themselves and what they do. So don't be afraid to approach people and say, hey, could I spend a day following you around and shadowing, as Jessica's suggesting, because people really love those opportunities to talk about what they do. Isaiah, you were going to say?
I was going to say, just from a practical employment perspective, that really all of these pathways are very much in demand fields. And my guess is, I know we're short-staffed. My guess is that all of these places, all groups There are huge opportunities, and there will be certainly roles to fill for, at the long foreseeable future.
Yes, yeah, boy, this is really a golden time for going into healthcare right now in terms of the opportunities that are out there. We're going to wrap up in just a minute. Shanabel, any closing words on this?
I was also just going to add that for pharmacy technicians, a lot of places, you just have to get certified within a year from your hire date. So you could even go and see if you like working in a pharmacy and take the course at one of the community colleges while actually getting the hands-on training as well, if that's something that you are interested in doing. I know here at UNC we do, you can come and become part of our team and get certified within a year. So it's always opportunity for growth there too.
That's a great idea. Thank you so much. I want to thank each of you. I want to thank the team here at UNC Lineberger Cancer Network, Veneranda Obore, John Powell, Oliver Marth, Andrew Dodgson, Naja Brown, and Patrick Muscarella for all of their hard work. We want to thank the people of North Carolina for funding what we do, which includes opportunities like this.